Today we will be covering the schizophrenias, which are a group of common major psychosis with a complex syndromal presentation, meaning that it is like a final common pathway, like in hypoglycemia, which can be due to a variety of causes, affecting young adults, showing chronic changes in behavior, perception, thoughts, and emotions, causing a fundamental disorganization in personality and deterioration from previous levels of functioning. Now, looking at the epidemiology of schizophrenia, which is quite a common condition affecting the population, uh, one very interesting characteristic is that it's a universal disease found in all countries at all times, and even much more uh, unique is that it is almost constant prevalence rates whichever country. There are some exceptions, but overall we'll find that it's almost the same wherever in the world we go, and the clinical presentation also has very similar features. The incidence is roughly about 15 to 20 per 100,000 per year. That is the new instances of schizophrenia that happens, that manifests. Prevalence is around 0.5 to 1%. So in the population we find about 0.5 to 1% having the illness at any time. Normal risk, that is when we look at the whole lifetime of a person, there is a risk of 0.7 to 1.3, or we say usually 1%. Now, we said earlier that schizophrenia is found in all countries, and it is fairly the same prevalence rate, about 1%. But there are some exceptions. Um, in some cultures and in some countries, we find that there is a higher incidence, and in some there are low incidence. So when we look at certain cultures, there is a higher incidence. For example, in northern Sweden, in Western Ireland, Catholics in Canada, and unfortunately Tamils both in South India and Sri Lanka. And we were able to establish this in our study, which we did in 1993 with Professor Ganeshwaran, Dr. Yoganathan, and myself. So what we found was when we calculated the incidence, it was around 34.6 per 100,000. And as I mentioned, some countries have low incidence. For example, the Anabaptist section of in the United States. Other characteristic features of schizophrenia is that it affects a very young population, the youth and early adulthood, around 15 to 45 years. The sex ratio is about equal, but there is an early onset in males. So females tend to get it a little later, and there is some evidence that female hormones, uh, particularly progesterone and estrogen, may be in a way protective. Now, there's been a lot of research, and it's very important also, particularly from a preventive point of view, and also to understand the illness, to try and find the etiology. And so far, what evidence shows that it is multifactorial, many causes which may combine in different different ways to produce the illness. So what we say is that there's a genetic component and there may be an environmental component, and uh, presentation, manifestation may differ. So you get a kind of a uh, uh, phenotypic expression that can vary depending on the combination of factors. So the hereditary aspect, the genetic component has been well established. There have been uh, quite a few family studies. It's been very clearly established that schizophrenia runs in families, and the more the genetic relationship, the higher the risk. So that evidence has been very clearly established. Um, for example, 40% of the patients usually have a family history. And in our study in Jaffna that we mentioned earlier, we found 63% have a family history, and that may give a clue why there is a higher incidence in among the Tamils, because there's a uh, 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 familial interbreeding, or people tend to get married within the family or the extended family. The cousins get married and so on, and that may be one of the reasons that it is much more prevalent in some cultures. So one of the strongest evidence for the genetic component is that when we look at the relationship, if both parents have the illness, the risk is 46%. So definitely the risk is high. If only one parent uh, schizophrenia, then we find that the likelihood of them, a child developing the illness, is 15%. While if both parents have schizophrenia, then the child is very likely or highly likely to develop schizophrenia. um, the risk if another sibling, the brother or sister, has the illness is again the same as having one parent. So that is quite uh, logical. The risk is about 10 to 14% of them have the illness. Now, in monozygotic twins, that is twins where they have the same genetic material, the same genes, the risk is, or the incidence is 42%. 42%. So if one twin develops illness, the risk in the other twin is around four, or the chance that the other twin will develop the illness is 42%. So it's almost like having both parents. While if it's dizygotic twins, where the genetic uh, similarity is like having a sibling, the risk drops to the same as for a sibling. So this clearly shows the genetic loading, how important genes are when the genes are the same. But it does also clearly show that environment is also important, because if the genes were the only etiological factor involved, if it's a completely purely genetic illness, we would expect, for example, if the monozygotic twins, 100%. If one twin develop the illness, the other twin should invariably develop it. So it shows that environmental factors are also important. So there's an interplay between the genetic and the environmental factors in causing schizophrenia. When we look at second degree relations, cousins and so on, and extended family, the risk is a little higher than in the normal population, which is, as we mentioned, around 1%. But in the secondary relation, the risk, the incidence is about 2 to 3%, double. So still, showing the genetic component is important. And there has been quite a lot of research into the possible genetic uh, genes involved, and one uh, uh, possible candidate is so-called the COMT gene, the gene that is responsible for catechol O-methyltransferase, which is involved in the dopamine catabolism, has been identified as a possible genetic marker. And this also is uh, goes with the theory, the dopamine theory. The dopamine is involved in schizophrenia. It is a neurotransmitter that is predominantly implicated in schizophrenia. Now, that is the genetic uh, component, and uh, we find that that's very important, but also environmental factors are as important. Uh, and we find that uh, conditions in the family, that is not the genetic component, but how the family functions. For example, in the relationships between the different members, the parents, the mother, how they communicate with each other. This has been also researched, and they have found that there may be um, various ways of uh, communicating, or the relationships that are very strongly emotional, something sometimes termed expressed emotions, amount of uh, emotion involved in the relationship. When it's very strong emotions, that may predispose. Um, Another um, uh, factor that has been identified is something called double bind messages, where uh, it is said that parents, or particularly the mother, may give uh, contradictory messages to the child as the child grows up. So the child doesn't know which is uh, the true, or what really the mother wants. So it's caught in what is called a double bind. The mother, uh, say, asks the child to kiss uh, her before going to bed, but shows through her body language, or from uh, previous uh, occurrences, that she doesn't really want the child to. But if the child doesn't kiss the mother before going to bed, then the mother may blame the child, saying the child doesn't love her or some. So the child is sort of grows up in this kind of, where he's not sure what the mother is trying to say, or is caught in what they call double bind. And of course, the mother has been blamed. Of course, this has not been established, and there's now a lot of evidence that shows that the mother is not. But there was a time when they believed that the mother, schizophrenic mother, they say, the way the mother communicates and relates to the child. So the one of the ways that they study the emotional content or the emotional relationship is this concept called expressed emotion, which we will have mentioned sometime later also. But it is composed of looking at the hostility. They're always critical and finding fault, and uh, fighting. Uh, it's a kind of relationship which the child finds hostile, or the parents or the relations may be very critical of the child, all the time finding fault, or the mother may be over involved, always uh, trying to uh, intrude into the life of the child. Whenever the child is trying to do something, or even trying to be alone, or going and lying on bed, the mother may go and uh, disturb the child, saying, "Why are you doing this? Why are you doing that? Why don't you do this?" Always involved in the life of the child. Now, other environmental factors that have been identified is, one is viral infections. For example, um, children born during certain uh, periods, for example, in Western countries during the winter, where there's a higher incidence of virus, viral infection of the mother, there is this theory that the child may be getting infected in utero. Uh, then birth trauma has been clearly shown to be, so. People who develop schizophrenia, if you look at their uh, birth history, there's a higher incidence of birth trauma. So possibly various injuries during birth. Endocrine factors have been clearly implicated. I mentioned about uh, females, their hormonal uh, hormones, the sex hormones may be protective to some extent, and they have shown that there's a higher incidence following partners when there's a precipitate drop in the levels of estrogen and progesterone, and that may be a factor involved in the high incidence of psychotic illness, schizophrenia-like illness following uh, delivery, labor, postpartum, and the later onset in females, as I mentioned. Um, Another uh, endocrine factor may be thyroid, hyperthyroid madness, myxedema madness. So uh, the endocrinal organs may be involved, the hormones that are secreted. Stress has been clearly shown to be so a stressful life event or a stressful period that a person goes through, adolescence, exams, um, love relationships, um, even trauma, post traumatic stress disorder. These seem to bring out a kind of psychotic illness, sometimes called reactive psychosis or psychotic reaction, where they may manifest with schizophrenia like symptoms, hallucinations, and delusions. But usually, prognosis is good when the stress is removed or when the period of stress is over. They may recover and they may usually make a full recovery. So, the prognosis is usually good when only stress is involved. But if they have also a genetic loading, they have a family history, and they are vulnerable in other ways, it may bring out the whole illness. Uh, so, um, trauma and migration. There's a condition even labeled migration psychosis, going to a new environment where they don't may not have social support, and they are under pressure to adapt to a new culture, the so-called culture shock. Person may become very paranoid and suspicious, and they develop kind of something called migration psychosis. And various physical diseases like encephalitis, pyrexia of unknown origin, antimalarial therapy, post surgery, various conditions where there is a physical insult to the body, where there is a strong physical injury to the functioning of the body, the person may develop psychotic illness. Another factor that's been clearly uh, found to uh, bring out an illness in some people is sensory loss, particularly hearing loss. In the elderly, sometimes called late paraphrenia, when as they age, they lose their hearing, or even at an early age, when they can't hear what other people are saying, they may become suspicious and paranoid, and that may evolve into a kind of paranoid schizophrenia, paranoid psychosis. Head injury, and that's been also clearly, particularly after the head injury, during the post trauma period, post head injury, they may develop. Epilepsy has been clearly shown to be involved in a uh, later development of psychosis, sometimes called epileptic psychosis. Quite a high, quite a substantial number of individuals with epilepsy develop a kind of psychotic illness later on. So, after having the epilepsy for a period, they may then start showing signs, symptoms of psychotic nature, and usually the epilepsy improves. The number of seizures or epileptic fits uh, actually decrease, while psychotic illness becomes much more severe. And it's very interesting if they have a seizure or if their seizure control is temporarily or for some reason lost and they have a full-blown seizure, they may show some improvement. So that is one of the uh, uh, features of ECT treatment also. Some patients improve with ECT. So even a seizure or in a epileptic patient who has epileptic psychosis may sometimes show a temporary improvement in their condition. uh, Drugs, particularly amphetamine, which is uh, a drug that involves the dopamine pathway. Uh, Clearly, they develop a kind of paranoid psychosis, schizophrenia, if, after abusing uh, amphetamines, methamphetamine, and drugs of abuse. Even the drugs used in for ADHD is one complication which we have to be careful and watch for. Drugs used in Parkinson's disease, because again it may be involved in the dopamine system, um, are well known to produce schizophrenia like illness, very similar. Cannabis also can produce something called a cannabis psychosis. Person can develop a schizophrenia like illness, psychotic illness. Multi-system connective tissue disorders like SLE, systemic lupus erythematosus, you can get a psychotic manifestation. Um, Socio-cultural factors, um, for example, it's quite clear that people in the lower socio-economic classes are much more, schizophrenia incidence is much higher in people who belong to, and it's not very clear whether that itself is the cause or people with schizophrenia tend to become unemployed, single, and drift into a lower social class. Um, and some populations, if you do various surveys, people who are homeless, prostitutes, in the prison population, you find that there's a higher incidence of schizophrenia. So again, this is whether it's etiological or whether it's a drift. People with the illness then tend to go into these kind of situations. They become homeless or they become they get involved in they break the law because of their behavior, and then they end up in prison. So quite a high percentage of people in prisons now, particularly in Western countries, that they have closed many of the long stay institutions, the insane asylums of older age all of past, maybe over the last few decades. There has been an increase in the prison population. Many of people who have been uh, sent home then end up doing very minor crimes, or they may be found to be causing a nuisance in public and they may be arrested. So these populations also you may find a higher incidence. And of course, as I mentioned, the single and the unemployed, there's a higher people with schizophrenia tend higher uh, number who are single and who are not able to work. They lose their job or they are not able to hold down a job. So whether it's a cause or the drift, because of the illness, they drift into these situations. Now, when we talk about the etiology, uh, these are socio-cultural and genetic factors and so on. But what is the final common pathway? How does it finally manifest in the body? If you look at it uh, in a microscopic or uh, at a biochemical level, and what they have identified is that some neurotransmitters are implicated, have a uh, role in the development of schizophrenia, and the strongest candidate so far and the most amount of evidence is that dopamine is the culprit. um, one obvious evidence is the drugs, the medications and the drugs used in schizophrenia, or the ones that cause schizophrenia like illness like amphetamine and so on, all uh, uh, have an impact on the dopamine pathway in the brain, particularly in the mesolimbic pathways. There are different dopamine pathways which we will cover in a short time. Um, the mesolimbic pathways may be involved with uh, hyperactivity, the dopamine activity, and some of the drugs that are effective in treating schizophrenia block, so they are dopamine blockers. There may be also some hypofunction in the mesocortical pathways, which we'll come to, which are more the cause of the negative symptoms, while the hyperactivity may be causing the positive symptoms in schizophrenia, which we'll also come to it into later. Uh, but the dopamine hypothesis has been found not to be sufficient. It doesn't explain everything in schizophrenia. There's long delay in the work in the benefit after using drugs, and uh, various research using neuroimaging and other postpartum studies and so on have not established dopamine as the sole. So other uh, neurotransmitters may be involved, and one strong candidate is glutamate. Uh, the and they have found that some receptors, the NMDA receptor, the N-methyl D aspartate receptors, they are maybe hypofunction, and they may be linked in some way to the dopamine pathways also, the balance. Similarly, serotonin has also been identified, and some drugs particularly work on the serotonin system. Now, looking at the dopamine pathways in the brain, there are several dopamine pathways. In fact, they have identified about five. Here we have actually made them into letters, so A, B, uh, C, D, and E. And uh, depending on the origin and where the pathway ends, the first one that is very important is the nigrostriatal pathway, starting with the substantia nigra and ending up in the striatum, the various nuclei there. And this is very important um, in, as you know, in Parkinson's disease and other conditions. In schizophrenia, the importance comes because when we use drugs that block the dopamine pathways, particularly drugs that are broad, that block all the different pathways, the one of the important side effects that we see in many of the patients, particularly the older generation, uh, is extrapyramidal symptoms, just like Parkinson's. They may mimic Parkinson's disease, pseudo-Parkinsonian side effects. So that is the first pathway, and that may be uh, important because of the side effects. Then we have the second pathway, which we call the uh, mesolimbic pathway, going to something in the limbic area called the nucleus accumbens, and this may be involved in regulating behavior, the pleasure that people are said to derive from various drug abuse, and also in schizophrenia, the positive symptoms of delusions and hallucinations may be result of hyperactivity in this pathway. So when we use drugs blocking these receptors or this pathway, that may be the benefit and the improvement in the positive symptoms, particularly the older generation of antipsychotics. But they have also found another pathway uh, going to the cortex. One is to the dorsolateral prefrontal cortex and to the ventromedial prefrontal cortex. And these pathways may be involved in the negative symptoms of schizophrenia. Um, the uh, dorsolateral prefrontal cortex is said to be involved in some of the cognitive symptoms, negative cognitive functioning, and so on. And uh, uh, the ventromedial prefrontal cortex may be involved in the affective, the emotional disturbances that we find. And some of the newer atypical antipsychotics may help, or is claimed that they help in alleviating these kind of negative symptoms. Then we have the tubero-infundibular pathway from the hypothalamus to the anterior pituitary, and this is involved in the release of prolactin. So one of the side effects of using dopamine blocking drugs is this uh, prolactin secretion may become dysregulated, and you may get an increase in prolactin secretion. And that is one way of studying the monitoring, uh, seeing uh, the effect of the use of antipsychotics, and what effect the atypicals may not be so, particularly drugs like aripiprazole may not cause increase in prolactin, but some of the other drugs are, they can cause quite a high increase, 3000, 4000 levels. And then there is another pathway that has been identified in the dopamine system, which is not very clear what its function is, and it is starts from various multiple sites in the uh, midbrain area and goes to various nuclei, including the thalamus and hypothalamus and various other, and it's not very clear what function it has. So trying to um, uh, summarize what we have been saying about the various pathways and the effect that it has in schizophrenia, trying to understand the symptoms based on the anatomy. This is from Dahl, the psychopharmacology book by Dahl, illustrated, and it shows in pictures, in images, what we have been saying. So, um, the mesolimbic pathway may be involved in the positive symptoms, um, the one that goes to the nucleus accumbens, and this is what we, by blocking due to the hyperactivity, you get the positive symptoms. So by blocking it, you can relieve the positive symptoms. Then the mesocortical pathways uh, to the dorsolateral prefrontal cortex may be involved in the cognitive symptoms, and the pathway to the ventromedial prefrontal cortex may be involved in the affective symptoms. So um, treating this is much more difficult, and usual drugs that we use in schizophrenia do not have much effect on the negative symptoms. It's claimed some of the newer atypicals have a more effective in changing some of the negative symptoms. The nigrostriatal pathway is important because of the side effects, particularly the typical antipsychotics that we used. They invariably produce some kind of uh, nigrostriatal uh, dysfunction, particularly extrapyramidal side effects. And the tubero-infernal pathway resulting when we use drugs. So when we are not using drugs, when a person may be having schizophrenia, that is untreated schizophrenia, you might find that these are normal. But then when you start the person on drugs, you get the extrapyramidal side effects due to blockage there, and rise in prolactin. So putting this all together, uh, they have come up with something called a neurodevelopmental theory, which um, says that uh, uh, the negative, some of the symptoms, the impairments that have been found, particularly in the prefrontal area, some of the neurological soft signs that have been found, people may be a little incoordinated, may not be able to carry out complex motor tasks, uh, maybe due to some developmental as a person grows up, maybe there's a genetic basis. So they have shown, they have done some neuroimaging studies and shown that certain areas of the brain, particularly the frontal lobe, there is some decrease in the functioning. So um, this is the hypothesis that is laid down in early life, the neurodevelopmental insult, and that it can cause some damage in the particularly in the prefrontal areas. So this is the kind of putting various factors here. The genetic predisposition, the genes are very important. Maybe up to even half the vulnerability in the person is due to genetic, but they can be also environmental factors, which we mentioned, various stresses and so on, which together may produce the neurodevelopmental changes or abnormalities. And these manifest as cognitive and social impairments and some soft signs. And the final common pathway for uh, these kind of etiological factors is dopamine and abnormalities in other neurotransmitters that finally manifests as schizophrenia. So this is a very complex illness, and there may be multiple factors involved. It's not all established clearly, but this is the current understanding. Now, symptoms of schizophrenia have much more recently been um, explained or have been categorized into positive and negative symptoms. This is uh, little different from the way that it was understood earlier, where they used to divide schizophrenia into simple schizophrenia, catatonic, hebephrenic, paranoid, depending on the symptom profile. This division into positive and negative is much more uh, helpful in understanding the cause and the treatment in management uh, to target. So there are drugs that are particularly effective against positive symptoms like hallucinations, illusions, and so on, and not so effective against the negative symptoms, which may need much more rehabilitative measures, environmental manipulations, and gradual process of activation, so that various negative symptoms like apathy and the four A's, so called apathy, amotivation, evolution, and socialization, can be addressed. And of course, the disorganization in thoughts and emotions that is so uh, uh, characteristic of schizophrenia, full-blown schizophrenia, florid schizophrenia, is something that is very difficult to treat at the start. So these are kind of pictorial, again from Dahl, illustrated uh, the different types of symptoms that schizophrenia presents with, and sometimes the treatment can be directed. So, for example, the drugs may be directed at the positive symptoms. The negative symptoms may sometimes respond to some of the atypicals, but usually you need rehabilitation and other measures to improve it. And these can be then divided into affective symptoms, aggressive and cognitive symptoms. The aggressive symptoms sometimes need very strong tranquilizers, like some of the strong benzodiazepines or even the antipsychotics with a higher sedative profile. All the chlorpromazine, haloperidol, uh, quetiapine, olanzapine. These are drugs that can be used when the patient becomes aggressive. Behavior is disturbed. So this is another pictorial representation of the picture that we get in schizophrenia when they manifest with the symptoms. So again, it's the same thing like the last one, but put in a slightly different way. So we have the positive symptoms, um, which are quite obvious and you can see them uh, quite clearly. Hallucinations, delusions, aggressive behavior, and the negative symptoms, which may become manifest only later on, and which are much more difficult to treat, and they are cause long-term impairment in functioning, particularly social functioning, family functioning, and so on. So the positive symptoms are the delusions and hallucinations, and they may be very assaultive or abusive. Affective, the emotional disturbances are like depression, suicidality, and loss of interest. Um, Cognitive symptoms affect attention, impaired executive functioning. They are not able to carry out or plan. Um, and so together they produce a kind of picture of reduced speech, lack of emotions, and apathy, kind of withdrawal, and they lose their motivation and drive, which are devastating, particularly in a young individual who should be very productive, working, uh, very involved in family life, in the society. They sort of withdraw and become not involved. So that is the implications of schizophrenia, particularly from a public mental health point of view and long-term management. So this is sort of artistic view of or drawings from a schizophrenia showing that disturbance in thought patterns. So one of the characteristic symptom in schizophrenia is thought disorder, where they get loosening of association and derailment and various manifested thought block and so on, and the thinking becomes disorganized. So this is a table showing some of the frequency of symptoms of schizophrenia, and this can vary. Different people, it can be, and it can vary even based on the culture. Some may be more prominent in some cultures, but generally, most schizophrenia patients don't have insight. They don't realize they have an illness. They may uh, believe uh, that there's nothing wrong with them. Auditory hallucinations, particularly in third person, is very characteristic. And we can get it in up to 74%. So it's worth looking for auditory hallucination. A lot of psychiatrists ask person as a part of a routine mental state examination whether they do experience any auditory hallucination. The easy way of establishing schizophrenia. Ideas of reference, delusion of reference is a little more severe form and maybe a little less common. Paranoid ideas, uh, um, flatness or blunting of effect, um, delusional mood, and delusional perceptions. These are a little more difficult to establish, uh, but delusional perception is a first rank symptom of schizophrenia. So these are also characteristic. So when we want to diagnose schizophrenia, um, Traditionally, they have used the first rank symptoms of Schneider, uh, which have to be present in the absence of organic disease. So, if they have some uh, organic brain pathology, then that takes precedence. That is the diagnosis. But in the absence of any organic, obvious organic pathology, like a brain tumor or uh, some kind of dementing process or infection, these first rank symptoms are diagnostic of schizophrenia. The most easy and maybe more common is auditory hallucinations, third person, thought insertion, withdrawal, and broadcasting. Maybe a little more difficult to establish, but it's again characteristic. Delusional perception is also sometimes called a primary delusion. Passivity, when the person feels that they are being controlled or that others are making them feel things or do things and so on. Somatic hallucinations. So these kind of symptoms were used classically to diagnose schizophrenia. But the trend has now moved a little more uh, broader, and both the ICD-11 and the DSM-5 uh, generally look at delusions, hallucinations as a category, and also look at the functioning, the change in functioning capacity, the deterioration in functioning. They give much more importance to that nowadays. Now, differential diagnosis is very important in schizophrenia, and of course, uh, very important from the management point of view also. So, it's always worth asking about history of epilepsy, um, particularly any seizures, uh, any history of childhood seizures, and so on, cerebrovascular diseases, cerebral neoplasm. So, as I mentioned, any organic disease of the brain that is fairly gross, obvious pathology in the brain can cause symptoms mimicking schizophrenia. Even some widespread infection of the brain, AIDS, uh, particularly when the brain is involved at some stage. Later on, it produces a dementia, like as you mentioned in a previous lecture. Um, Substances, particularly amphetamine, has been uh, clearly implicated in schizophrenia-like illness. But other hallucinogens and alcohol alcohol can produce a paranoid psychosis in later chronic use. Now, these are some of the medical uh, differential diagnosis. Then we have some so-called psychiatric differential diagnosis, where other psychiatric diseases may resemble or may mimic schizophrenia. So already I mentioned about brief reactive psychosis, where there is a strong stress factor, acute presentation, but with a good prognosis. So once the stress is removed or they cope with the stress, like a trauma or a migration, they recover. They make a full recovery. Schizoaffective disorder, where there are mood symptoms, affective symptoms, depression usually, or it sometimes can be manic, and the picture can vary from one to the other, or it can both present at the same time. You can get a condition called schizoaffective disorder. Then affective disorders, particularly mania, can be misdiagnosed as schizophrenia. Delusional disorders, where you may not get hallucinations, you may not get so much deterioration in functioning, and it usually delusional disorder you may get it in later life. possession states. So these are subcultural uh, behavioral something that you find in some cultures, and they should not be diagnosed as schizophrenia. Yeah, they may behave in a very odd and bizarre way, or they may believe that they are under the control uh, of some other spirit or some other being possesses them. So you might think it's some type of passivity, but it's a subcultural phenomena, and it should not be diagnosed as schizophrenia or psychiatric condition. Various personality disorders, particularly the schizoid personalities, uh, where you get a kind of autistic loneness and the person withdraws from society, um, may mimic gradual insidious onset of schizophrenia. Obsessive compulsive disorder, where they have very strong images and intrusion of thoughts, sometimes of uh, delusional intensity, sometimes this gets misdiagnosed. So that also you have to be very careful. Comorbidity. So very often schizophrenia, uh, particularly when the initial onset or during the course of the illness, quite a high percentage develop depression, maybe around 25%. So that is something we have to look for, and sometimes it needs treatment on its own. Obsessive compulsive symptoms may be part of the schizophrenia. Anxiety again, and substance abuse, so-called dual diagnosis or dual uh, conditions. Uh, many, particularly in Western countries, we find that many chronic schizophrenia patients uh, use alcohol or other drugs, and sometimes the drug dealers target persons with mental illness as somebody easier to get them to buy the drugs and use, make them into dependent people. Right. Finally, we come to the management of schizophrenia, which is quite a difficult uh, condition to treat, and it takes quite a lot of the time and effort of mental uh, health work. And we generally put it under a what we call a biopsychosocial approach. That is, we target all this. It's an integrated person, has to be seen as a whole, but it may be helpful to understand it, looking at these different components. So the bio component will be mainly the drug management using various drugs, other physical like electroconvulsive treatment or other physical methods, psychological management. Um, some psychological treatments have been found to have some benefit, particularly working with the family, and very important is rehabilitation. Particularly in chronic schizophrenia, negative symptoms, the whole rehabilitation process, which may take months or years, is very important part of the management. So initially, the pharmacological management may be needed to control the symptoms, particularly positive symptoms, the behavioral disturbance, and so on. But then the rehabilitation. So um, that is a very important part of the whole management, and then working with the family, because ultimately the family may be involved in managing, particularly in a third world country. The family family looks after the person with schizophrenia, so we have to work with them to educate them, uh, to communicate, give them information about the medication, the importance of regular use, of the side effects, and how to tolerate some of the behaviors of a person with schizophrenia, how to keep him active. So in the rehabilitation, they become co-therapists. So they can be part of the process of recovery. Now there's a lot of emphasis on recovery, And teaching is that person with schizophrenia can recover. I'll come to that later in the prognosis. And if the rehabilitation and the pharmacological management is done uh, thoroughly, we can expect the person to recover. So the family should be encouraged to carry out the rehabilitation process at home. So the pharmacological management uh, is mainly using the antipsychotics, and we have had the typical antipsychotics from the 1950s, which were very effective, made a dramatic change in the whole management of uh, schizophrenia. Uh, Asylums uh, were closed. People were then discharged into the community. That's all mainly due to the antipsychotics that came on the market. And famous drugs, quite old but very effective: chlorpromazine, trifloperazine, haloperidol are the main drugs. For a time, pymazide was there; it's no longer in use. Droperidol is sometimes used in acute management, but the mainstay, and they still continue to be effective, can be used. Chlorpromazine, trifloperazine, and haloperidol. They still have a space, although they produce quite a bit of side effects, the extrapyramidal side effects, and that is the reason that the atypical antipsychotics are now being used. They don't produce so much of the side effects, particularly extrapyramidal side effects that were produced by the typical antipsychotics. So we have drugs like olanzapine, very effective, uh, risperidone, quetiapine, and also amisulpride. It's quite effective. Unfortunately, some of these drugs produce what we call a metabolic syndrome. They may put on weight, get diabetes, heart disease, and so on. So they have to be also monitored, and these drugs also have side effects. The drugs like ziprasidone and aripiprazole, which are partial antagonists of dopamine, do not produce these kind of metabolic side effects. So they may be preferred in that sense, and they have a role to play in the treatment of schizophrenia. Clozapine is a very effective drug. Unfortunately, it has sometimes fatal side complications, particularly blood system, granulocytosis, and so on. So, but if it's used uh, cautiously with close monitoring of the blood levels, and if the indications are very clear, it's very effective. So, clozapine has also made a dramatic change, particularly in the prognosis in drug-resistant schizophrenia, which where they are not responding to the other medications. Clozapine works. So, as I mentioned, selection of drugs depends on various factors. In a third world country like ours, um, the availability is controlled by the cost factor. Um, then we have to look at the side effect profile. So, if they are causing a lot of extrapyramidal side effects, then we go for the atypicals. Symptom profile. So, there are a lot of positive symptoms, aggressive behavioral disturbance. We may use the more sedative drugs like chlorpromazine or quetiapine or even olanzapine. Then the person may be having some sensitivity to some other drugs. So again, we look at the specific contraindication. People who have been using a particular drug and they're familiar with the drug may prefer to stay in that on that, and then of course the cost. So what can be provided through? So we are going on with the management. The patient is brought to the ward, usually in a very disturbed state, and we may need to settle him very quickly. Then we look at the controlling the acute psychotic symptoms. then treating the long-term treatment of resistant schizophrenia. So, for initial tranquilization, we usually use the rapidly acting sedating antipsychotics, for example, olanzapine, chlorpromazine, haloperidol, and at an earlier time droperidol. Many of them can be given intramuscularly, or if the patient is taking it orally, that is preferred. There is also a role for using the benzodiazepines for initial tranquilization, as they are very sedative and they can calm the patient very quickly. Any of the benzodiazepines, particularly drugs like midazolam, even lorazepam or clonazepam, any of these can be used for the first few hours or days to quickly bring the patient under control. But in the long run, we'll have to depend on the antipsychotics to work on both the acute disturbing behavior and the positive symptoms, and that may to some extent depend on the profile and on the manifestations and the side effects. When we treat schizophrenia, we find that some are very resistant to most of the oral antipsychotics that we have available. So, we usually give a trial of both typicals and the atypicals, and after give them a fair period, maybe it's few months, and if they still don't respond, they continue to have disturbing symptoms, dysfunction, we may then choose to use clozapine. Clozapine is a very powerful drug, very effective, and works on positive and to some extent negative symptoms. There are very few side effects except the metabolic side effects and unfortunately the effects on the blood. So, it can cause blood dyskaryosis like agranulocytosis, and we have to monitor the blood very regularly. Can also have an effect on the heart, so we have to check for myocarditis and other complications. It can have hypotensive side effects, can cause excessive sedation and seizures. So, clozapine is a drug that has to be used very judiciously, monitoring the clozapine blood levels. So, they are well established therapeutic levels, toxic levels, and regular monitoring can be done if it's available, and we have to watch for side effects and follow up the patient very regularly, but the effectiveness is very high. So, clozapine is a drug that we can use. Sometimes it can be used even from the start if the patient is very suicidal, showing signs that are very disturbing. Some clinicians may even decide to use clozapine, but generally we reserve it for the resistant schizophrenia. Another helpful alternative we have is the depot injections that are available to treat patients in the maintenance part of treatment. Even for acute management, there are some depots that last for a few days. Acute-phase that can be helpful in acute management, but usually the depot preparations are used for long-term management when there is poor compliance. Patient can be given depots that work for 2 weeks or for a month, and they can be followed up. So, these injections can be given in the community by community mental health nurses or others trained in giving injections. So, a patient can be visited at home, but usually there are special clinics, depot clinics, and patient can be monitored whether they turn up for the injection. If they don't, then they can be reminded and so on. So, it's a very useful treatment option that we have, particularly patients who have poor insight and do not comply, because the commonest cause for relapse is poor compliance. So, we may be now at a stage, or we have come to the stage where we are able to discharge most patients within a fairly reasonable time. We can use the currently available drugs, and they make a reasonable recovery. Some have a very good recovery, as I will now mention later on when you look at the long-term prognosis. Some do have some residual symptoms, but with the current modern drugs, we are able to manage them in the community. So, with this advance in the therapeutic regime that we have, it's been possible to change the whole picture, the clinical picture, the clinical prognosis, the long-term course of the illness, and we are able to manage the patients at home. So, some of the old asylums, mental asylums, where patients used to be locked up for months or sometimes for life, are now being or have been closed, and the patients are now discharged home to be looked after by their family or a team in the community. So, very important part of the long-term management, particularly because now we are going to involve the community, the family, other institutions, sometimes the workplace. It's very important to educate, public education, to tell the family, the managers at the workplace, what we are dealing with, what is this illness, what are the common symptoms, what are the behaviors that we can expect, what can be tolerated, what are early signs of relapse or worsening that they may need to note and then may need to take some action. So, what we call the early warning signs, I will mention later, and the side effects of drugs, because they should be able to recognize the side effects and take necessary action. So, there is a lot of public awareness, psychoeducation, and in a way that will also help to reduce stigma. The negative stigma around schizophrenia is a big problem. So, psychoeducation is very important. And we need to support the patients, particularly when they are going through the acute phase. It can be very disturbing. They are experiencing symptoms that are very distressing. So, it's very important to be reassuring, supportive, to talk to them in a calm and reassuring way, and the family also will be disturbed by seeing their relation in this state. So, they also need to be supported. They may need economic support, they may need social support, and they should be always cared for. The carer, the key person who looks after the person with schizophrenia when they go home particularly, also will need long-term support. So, there are sometimes carer groups and carer support systems. Sometimes they need some relief for a time, so the patient can be admitted to the hospital for a few days, so that the carer or the family can get some respite. So, all these type of long-term management issues have to be looked at. Some patients, they have shown, who have long-term hallucinations, auditory or delusions that are fairly fixed, do respond to certain psychotherapeutic techniques, particularly cognitive behavior therapy. If they are cooperative and willing and have some insight, and the drugs are also working to some extent, they can be changed. And there is also now a whole field of cognitive remediation to try to change their ways of thinking, their cognitive skills in memory, attention, carrying out a task, planning. so-called executive functioning and so on, which makes a big difference in their long-term outcome. They are able to go back into the community and interact with society and so on. And a very important part of the whole program of rehabilitation and reintegration with society is to teach the patient basic skills. Although they may have known them before the illness, some of them may not have really, because the illness started at a very young age. The skills, sometimes due to prolonged hospitalization. So simple things like going into a shop to buy things, how to pay their bills, to go into a post office, or how to manage a bank account, how to cross a road, how to look at both sides of the traffic and when to cross, to use the crossings. So simple things that we take for granted may need to be taught to the patient in a very professional way, step by step. Say chaining methods, one step at a time, and they can be taught even self-care, putting on their clothes and washing their face and so on. How to talk to others, communications, how to talk to a person to deal with an administrative issue. So there's quite a lot of scope to improve their social skills. So this whole field of rehabilitation has now come into a lot of prominence, and people are spending a lot of effort in trying to promote what is called recovery. The whole concept that a person with schizophrenia is having an illness and they can recover if they are given the appropriate treatment and also the skills and the environment. So the whole goal is to help them reintegrate back into their family or into society, to have the necessary skills to live independently, so that they are able to do attend to their needs by themselves. So there are a lot of effort and a lot of research and practical steps in doing rehabilitation. So that is done in stepwise way, self-care, how to look after themselves, washing their face, clothes and so on, stepwise, slowly, instead of saying that they can't do these things. So activities of daily living, ADLs, that is first step, very important to make them independent. Then the cognitive remediation we talked about, attending, communication skills, ability to concentrate, and vocational training, working in a supportive environment. It improves the prognosis considerably when a patient is able to work, even if it is for a few hours, for 2 hours or 4 hours, if they are able to spend their time in a very constructive way, the whole activity is structured, it helps in the long-term management. So apart from their self-esteem and their confidence growing by being able to hold a job and earn some money which they can then spend, it also is very helpful in the management of schizophrenia. So vocational training is very important, something that they would be interested and at their pace, so that we don't have a unrealistic goal. It's quite a lot of successful vocational training has been done. And then once they know a job or they want to work, very important to prepare the work environment, and it's very important to communicate or to teach supervisors, managers at the workplace not to be too demanding, not to put too much pressure, to let them settle in, so that they can't be insistent that they are working full 8 hours or whatever that they are needed, and that they can't take some time off, few minutes. Sometimes they need to go have a walk around. Sometimes they become preoccupied. Sometimes their attention and concentration may not be up to date. Sometimes certain days they may not be so cooperative, they may become irritable at times. So, if they are able to tolerate this and the environment is made little more less stressful, many of these patients do very well, and they will find, the employer will find in the long term having them is profitable. They will stay in the job, like unlike other employees who may move on and so on. They become loyal and they will stay on, and they will help with the particular industry they are working in. So, now lot of industries, and by law in some countries it is required that certain percentage is reserved for disabled people, including mentally disabled, and so 5%, 2% of their workforce will be disabled, and by having them on their workforce they get some benefits from government and so on. But it is profitable also, so it is very important part of the management. And this kind of rehabilitative effort is helpful in managing the negative symptoms that do not really respond to the drugs we have. The real treatment for negative symptoms is rehabilitation, and it gets them out of the homes and out of the hospital. Earlier they used to be warded for months or years. They become what you call institutionalized, so they are completely dependent on somebody giving them the food, the drugs, wearing the same type of clothes. So, to get them out of that environment into the community. So, the whole field of rehabilitation is very important part of management of schizophrenia. So, this is the kind of and they have developed various types of institutional structures. Genetic predisposition, the genes are very important. Disability, maybe up to even half the vulnerability in the person is genetic. But they can be also environmental factors which we mentioned, various stresses and so on, which together may produce the neurodevelopmental changes or abnormalities. And these manifest as cognitive and social impairments and soft signs. And the final common pathway for there are just leisure activities, kind of etiological factors is dopamine and abnormalities in other neurotransmitters that finally manifest as schizophrenia. So, this is a very complex illness, and there may be multiple factors involved. It's not all even more disabled established clearly, but this is their family is not able to look after them. Persons with schizophrenic illness who are reasonably independent can be put together, and so starting back with the daycare centers and hospitals that are very important. Some patients are much more disabled and they are not able to even perform. They are not able to come to daycare center. Sometimes their support, family support, social support is lacking. So, they may need to be kept in a what we call a halfway home, where a group of patients with schizophrenia live together. Sometimes they cook, taking turns, they clean up, but professional community mental health nurse or social worker can visit them on a periodic basis, sometimes daily, sometimes weekly, sometimes monthly. So, depending on the severity of the illness and their need, these kind of supported accommodation facilities can be arranged. In most Western countries, these are available, and we may be going towards this here in our part of the world also. And as I mentioned, occupational therapy is a very important component. It is part of the whole rehabilitation, even during the acute management, to slowly start person back in their daily responsibilities, daily living skills, and to deal with the outside world, to start doing some cooking, to be involved in daily activities like walking, going out for some play activities. So, all this can be done through the occupational therapy treatment program. They are trained occupational therapists who will look after this, and they are trained how to get the patient well gradually to bring him out of the severe illness that they were in. And as I mentioned, vocational training, this has to be tailored to the special skills and interests of the patient. You can't just impose a particular vocation on a patient. Sometimes it can match what they have done before. So if they have been a carpenter or an electrician, or so the vocational training can be built on that what they have previously acquired. And as I mentioned, the environment has to be very supportive. The home environment is also another very important aspect that we look at in the long-term management. Even in the acute management, there are some centers, for example in India, where they are able to manage the acute patient in their home. So they provide all the support, daily visits by the nurse and doctors, and the family is taught how to deal with the patient. So they don't have this traumatic experience of being put into a ward and treated there, which can be also disturbing by itself. But in the long term prognosis and the course of the illness is determined to a large extent by the home environment, particularly the emotional content, as I mentioned, and we will come back to that also later but we can teach the family how not to be too involved, not to be too emotional, not to be too critical and hostile to the patient, to be supportive, accepting, give them space and time, to be understanding, but also at the same time not to let them deteriorate or don't let them go completely into a passive private world. So they have to be drawn out, to be made active, to get up every day, attend to their needs, do some activities, involve them in whatever is going on in the family or society. So there has to be a balance, not too much of one side. So in our setting we have done some what we call agrotherapy. There we teach them how to look after, it's like a home garden, so that once they go home also they can continue doing this at home. It's a good way of using their energy, time, effort in a constructive way. It's very effective. And there's a lot of work to be done with the family, as I mentioned, educating them about the illness, about the side effects, early warning signs, what to expect, how to behave with the patient, and so on. And teaching better coping strategies, what to do when if the person gets angry or upset. Both the patient and the family can be taught. Once the patient starts recovering, they can be taught many skills, anger management and so on, how to cope, what to do if a situation is getting out of hand. They can go for a walk, or many of them can help keep them out of hospital. Familiarize them with the medications, the side effects, what are the early warning symptoms, and so on. So all these type of skills can be taught to the family. And particularly important is the whole concept of expressed emotion, which I mentioned earlier, and I'll come to later also, the emotional content in the home. So schizophrenic patients need some protection, some sheltering. So they can't be too demanding, the family can't be too critical or hostile, and at the same time they can't be too over involved. They can't be all the time intruding into the patient's private space. The person needs some time to be by themselves. So this whole concept of expressed emotion needs to be again tailored and finely balanced, which we can work with the family to, and we can see that the whole course of the illness can be determined by the level of emotion at home. So as I mentioned, some patients tend to withdraw, not become involved, and they trying to avoid social contact, try to avoid activities, but they have to be encouraged to get up in the morning, attend to their self-care and so on.
go for work and take some responsibilities involving social activities, go to the temple or church and so on, in any kind of festivals. So this also takes a lot of effort, lot of burden on the family. So they need a lot of support, but they may be willing to do this if they are given the right knowledge and support and skills. Sometimes this is done through a program called family groups. So families of schizophrenic patients come together, and a facilitator can then teach them these various skills, give them information, be supportive, deal with their worries and concerns and so on. So the family groups are another very powerful way of keeping the families supported. And some family members, particularly the carer, may themselves become stressed and find it difficult to cope, because day in and day out they have to deal with the schizophrenic patients who may be having hallucinations and delusions and behaving odd way from time to time, maybe getting into relationship difficulties with neighbors. So it can become very stressful for the family members. So they may need a lot of support. They can be given supportive counseling. Sometimes they need relief. So sometimes the patient can be admitted to hospital for a few days so that the family members get a break. Or they can go off on a holiday. So all these mechanisms are now being put in place to keep the schizophrenic patient in the community, and it's very effective. Now, just coming to this concept of expressed emotions. Now, this is a study that was originally Julian Leff in the Institute of Psychiatry in London, but this has been replicated all over the world. And what they have found is that the emotional content at home is very important in the long-term outcome. So here what they have studied is the relapse rate in schizophrenia over a period of 9 months. So patient is in the hospital, is diagnosed with schizophrenia, discharged home, and then they follow up to see if they are having a relapse or not. So what they use is this concept of expressed emotion, which is determined by looking at these factors: hostility. So if the relations are very hostile to the patient, always criticizing him, finding fault, scolding him and so on, then they get a high EE score. Similarly with criticism, if they are being criticized for not doing anything or for causing so much trouble for the family and so on, that is high score. Similarly, over involvement. So if the mother or somebody always goes into the patient's bedroom, trying to question what he is doing and why he is lying down or where he is going, so this kind of over involvement. So all these are looked at, and if they is found to be high, they are given a high EE score. If they are low, they are called low EE. So we have two categories of homes: low EE homes and high EE homes. So if the patient is discharged to a low EE home, that is to a home where the emotional content is low, it doesn't seem to make much of a difference if they are on drugs, on maintenance medication or not. The relapse rate is almost equal. So you can see how important the emotional content is. Now, unfortunately, the patient is going into a home where the emotional content is very high, where the family is hostile and critical and over involved, which usually tends to be the case. We find that if you look at use an arbitrary division called face-to-face contact, that is how often the family members are confronting, coming face-to-face with the patient, and look at the time that this happens. So if it is over 35, this is a figure that they have arrived at, which happen to be significant. So what they have done is over 35 hours of face-to-face contact, excuse me. Over 35 hours of face-to-face contact and lower than 35 hours of face-to-face contact. Two divisions. So, high E home over 35 hours and lower. And then they see whether they are on drugs or not. So, if the person is going into a high E setting, but the face-to-face contact is less than 35 hours. So, the family members are not so often with in their they are communicating or coming into relationship with the patient. If they are on drugs, if you give maintenance drugs, the relapse rate is almost the same as going into a low E home, that is, it's very low. But if they are not on drugs, relapse rate is 42. So, in this situation, it shows that if they are going into high E homes, it's very important that they are on maintenance medication to make sure that they are complying. That it's almost a threefold difference. So, this does make a difference. Now, if you look at the over 35 hours face-to-face contact. So, this is high E home and over 35 hours of face-to-face contact, and if they are not on drugs, relapse rate is almost 92, almost sure they are going to relapse. So, it's like you are almost sending them home to come back. But if you can maintain them on drugs, put them on maintenance drugs, you can half that. So, you can see the importance of drugs here, and you can also see the importance of the low E home. So, this is a very important, important study that shows the importance of managing the environment where the patient goes. Now, we look at the other factors that we can do in the community, at a community level, public health, public mental health. So, increase the awareness in the community about illnesses and what causes the exacerbation or relapse, how to behave with a person who has a mental illness. So, many of them are stigmatized and they are treated in a very negative way. Some communities we find that they are even they may throw stones or crack jokes and made fun of. So, we have to work to try and increase this kind of negative behavior and to reduce the stigma in society. Mental patients with chronic illness like schizophrenia tend to be stigmatized and marginalized from society. So, they are kept away from social functions, festivals. Sometimes they used to be kept locked up or chained in their homes because, and the family members also sometimes get stigmatized, and they are not able to go and take part in social functions. So, as I mentioned, avoid provoking like joking and making fun of them. Important for rehabilitation. So, the community is also involved in the rehabilitation and the community care. So, for example, community nurse going and giving the depot injection, making sure rehabilitation is going on, how the family is getting on, whether it needs any help or support. So, all this is very important part of the community care. So, this is what we call follow-up. So, there should be a mechanism. Once the patient is discharged, they are handed over to the community team who will have them in their records or books, and they are regularly monitored and followed up to make sure that they are stable in the community. Otherwise, they may become homeless and start wandering and get into medical legal problems. Now, I mentioned earlier in the whole education process and also teaching the family and also the patient how to monitor, how to be aware that the illness may be happening or coming on again, that there is a risk of relapse. And these are early warning signs that have been studied and shown to be very important. First is usually insomnia. Patient starts losing sleep, they become more irritable sometimes, they start getting angry, they get upset by very small issues. Their work performance starts declining, so they don't come for work, they come late. Student performance in the class may start declining. So, these are signs that we have to do something. They may need an increase in the medication, or they may be non-compliant, which is usually the case. So, start the medication again and hope it does not go into a full-blown illness. Medication can be started early, you may prevent a full-blown relapse. They may become very aggressive, which is usually the point where people, families get worried and start taking action. But if they can take it earlier, it will be better. Some patients get withdrawn, they stop eating, they stop coming out of their room, they may neglect their self-care. So, that is also another serious development, very important to start doing something at that stage. They may refuse drugs, this may even come early on, and that is an early sign that definitely something is wrong. And psychotic symptoms, auditory hallucinations, delusions may become more prominent, may become overt, and they may be completely disinhibited in showing these signs. Earlier they may be very careful and secretive, but now they may be just out in society also, they may show some of these signs. So, the long term picture of schizophrenia, unlike the old days when people used to believe, which is again part of the stigma, that this is an illness for life and they are mentally ill and it's hopeless, they are not going to recover. So, that type of idea was there, and that was the reason that schizophrenia was earlier called dementia precox. Kriplin initially labeled schizophrenia as dementia precox because he believed that it is a chronic downhill course and they start dementing at a precocious age, at a very young age. But now they have found, particularly with the current treatment and or the recovery model, 30% of patients will recover, come back to their previous level of functioning. So, that is quite a high amount, and they can go back to their families, they can go back to work, they can lead a normal life. So, it is very important to be aware of this, and particularly they have found, I will come to that later, early the treatment is started, the better that this kind of outcome will be seen. 30% will recover. So, they will get over that very disturbed, very a lot of positive symptoms, that very distressing, but they may continue to have some residual symptoms, some hallucinations, delusions may be there, they may not be able to work like before. So, there may be some disability, but with support they can be managed, and they may be able to go back to their family and sometimes to work. So, it is very important to aim for maximum level of functioning. Then we have 30% that are chronic with residual symptoms, and these were patients who earlier needed institutional care and now may need to be kept in their home with a lot of support systems in place. Very important for the maintenance, for the continuation of drugs, maybe they may need a depot injection and the family will need a lot of support. And unfortunately about 10%, particularly when they develop the illness at a very young age, adolescents, for a period the illness may get worse despite all the active treatment, they may get worse till the illness burns out. So, you get a kind of period of maybe a few months or years, they are acutely ill, and then they may reach a plateau, and then you have a kind of residual, sometimes called burnt out schizophrenia. So, if you look at the long term course, you can divide it into sort of pictorially, you can picture it this way. The one that is with a good prognosis is what we call a brief reactive psychosis, and it is usually due to some traumatic event or some stress that they face, and it causes rapid deterioration in their level of functioning, behavior, and they have all the positive symptoms, and that may go on for a few days or weeks, but then they make a full recovery. All the symptoms subside and then they are normal for life. So, that is brief psychosis, very good prognosis. So, you shouldn't actually call it schizophrenia. So, people sometimes do not call a psychotic illness schizophrenia till the illness has gone on for say 6 months, because you may be dealing with a reactive or brief psychosis where the patient is going to be normal for life, and if you give them a label of schizophrenia with the stigma and all these other issues, you may condemn them for a lifelong label. There are a group of schizophrenias where they only have episodic illnesses. So, for every few years, sometimes it's even every few months, they may have periods where they experience symptoms like hallucinations, illusions, change in behavior, and they may need hospitalization, but they make a full recovery and then they go back to normal family, social life, usually on maintenance treatment. But then something happens, they stop taking the drugs, or they reduce it, or something happens at home and there is some traumatic event and they may get a relapse. So, like that, and then they make a full recovery. So, their whole life, over their whole lifetime, they may have few episodes of illnesses. Then there is another type of course of illness where the initial illness may cause deterioration in all aspects of life, particularly behavior and cognitive functioning, social functioning, and so on. Then with treatment, there may be some recovery, but they may not get back to their earlier level of functioning. There will be a gap, so there is some disability, and they may continue at that level for some time, then they get another relapse, and the deterioration may be more than earlier. They make a recovery, so a few weeks or months of the illness recovery, but not to the earlier level. So, like that they continue to have relapses and their general level of functioning is deteriorating. So, they never reach that previous. So, each time so it's very important to prevent these relapses. That is why long term maintenance and monitoring and so on is very important. Finally, there is another group of schizophrenia, like the ones we talked about, the dementia precox type of picture, where they may never have a severe breakdown like here, where there is a marked deterioration in functioning. It is just a gradual insidious onset and gradual deterioration in functioning. So, slowly they withdraw from society, they do not get involved, they stop working, they may be single, not interested in the opposite, and they just deteriorate slowly. And very often this shows there are signs in say neuroimaging, where there may be atrophy of the brain, ventricular dilatation and so on. So, these are the different types of course pictures in schizophrenia. Finally, we look at the prognosis. Again, all these are interrelated, but a lot of research has gone into this, and it may help in the management and in also talking to the family of what to expect. And we can also tailor the treatment, how long we need to treat and what drugs to use, whether to go for a strong drug like clozapine, depending on certain prognostic indicators which can tell a clinician whether we are dealing with a good prognosis or a poor prognosis. And from research they have found that certain factors like sudden onset is usually indicative of a good prognosis, while an insidious gradual onset where there is no clear cut even symptoms at the start, prognosis is poor. If the illness starts at a later age, particularly in the late 30s or 40s and so on, prognosis is very good. Usually their personality is preserved, they are able to continue to work, they are able to relate to people, but they may have some paranoia and so on. While if the illness starts at a very young age, particularly the adolescent period, the prognosis is poor. It seems to affect all levels of psychological functioning, cognition, emotion, behavior and so on. If there are clear precipitating factors like a traumatic event, stressful, or even a physical illness like an encephalitis or even malaria or whatever, that causes the onset of the symptoms, prognosis is good because they usually recover once those precipitating factors are taken out. If there are no clear precipitating factors, prognosis is poor. If their pre-morbid personality is good, they have been working regularly, have a family life, they are sociable, and they have an illness, prognosis is good. While if they have been withdrawn, isolative, schizoid, no, not many friends, cold personalities, prognosis is poor. There's no family history, so there's no known genetic cause, no previous history, prognosis is good. While if there is a positive family history, strong genetic loading, and there's a past history, prognosis is poor. They say if there are prominent affective symptoms like anxiety, depression, if that colors the schizophrenic illness, prognosis is good. While if there is lack of affective symptoms, prognosis like blunting, apathy, prognosis is not good. Early treatment, as I mentioned. So, the shorter the period between the onset and the treatment is started, better the prognosis. Longer the period, longer you delay treatment, the worse the prognosis. So, very important to catch them early and treat them very aggressively from the start. Quick response to treatment. When you give drugs, if you see the patient improving, that shows that is good prognosis. While even though you use all the drugs in heavy dosage and try different drugs and the treatment and they are not recovering, prognosis is poor, and that may be an indication for clozapine. Compliance with medication and insight is again good prognostic sign. Low E home, as he mentioned, if they are going into a home, emotional content is low, prognosis is good. While the opposite is true if you face these kind of environments. If they are working regularly, they hold their job, prognosis is good. Similarly, marriage. If they are married, they have a family, particularly supportive wife and children, prognosis is very good. If they are alone, they are not married, they are single, they are not working, prognosis is poor. And a family that is very supportive, understanding, concerned, very helpful. Not too much like high E, but they are very supportive. They provide the food, a place for them to stay, not too critical. That's good prognosis. So that is schizophrenia.